I'm Raman Bhakhri. I teach at ICO, and today's presentation is intravitreal aflibercept 8 milligrams for DME. These are the week 96 efficacy outcomes by baseline characteristics in the phase 2-3 Photon trial. No disclosures. The study was sponsored by Regeneron. Did include human patients. IRB approval was, of course, obtained, and there was some medical writing that was used in the study as well. So a little bit of background. So in the Photon trial, there was 8 milligrams of aflibercept, also known as Eylea HD. It demonstrated non-inferior BCVA gains with extended dosing intervals compared to standard Eylea, aflibercept 2 milligrams in patients with known DME or diabetic macular edema. There were no new safety signals, which was obviously good news, and that was through week 48. The influence of baseline patient demographic data and ocular characteristics is still yet to be known on the treatment effects of this 8 milligrams at 96 weeks, so that's what we're investigating. So this analysis basically assessed whether visual improvements achieved with 8 milligrams versus that standard 2 milligram dose at week 96 were comparable across several patient subgroups. So real quick, the actual study design, it was a multi-center randomized double-masked study in adult patients with center-involving DME. The groups were 3 groups that are randomized. 2Q8 means 2 milligrams every 8 weeks. We have 8Q12, which is the 8 milligrams every 12 weeks, and then 8 milligrams every 16 weeks. You can see there was a little bit of a priming dose given to all the patients. That's up there for you guys. The endpoint was at week 48, and that demonstrated that was non-inferior gains in terms of mean change in BCVA. There was an end of study at week 96 with an optional 1-year extension. So what are some basic patient baseline characteristics that the study looked at? They're all up there. Age, percentage of females, and conversely the percentage of males. Race, whites, blacks, Asians, others, Hispanic or Latino. Duration of diabetes, history of hypertension, BMI. Obviously entering best corrected visual acuity. CRT stands for central retinal thickness, so what was it coming in? And then prior treatment for DME. Now you might look at that one and go, why are people who've already had DME put into the study? There was a washout period, so if you've already been treated with anti-VEGF, you were given a 12-week washout period. If you're treated with laser, same thing, 12 weeks. Steroids was 16 weeks. It's usually Ozurdex for that 16 weeks. This is the actual study results. You can see basically right around here, again, non-inferiority, basically the same type of results. Now when we actually look at it by demographics, we can look at the first one, that's age. You can see the groups were 55 or less than 55, between 55 and 65, and then 65 to 75. Some of you might have already picked it up already. What about those older than 75? There just weren't enough patients to draw conclusions from, so they're not included in the study. When you look at the subgroups, change in BCVA was basically same between the different subgroups. So again, pretty similar throughout. When you look at it by gender, obviously male and female, you can see that again, you're having the same type of gains regardless of it's male or female, and regardless of whether it's a 2, 8Q12 or 8Q16. When you look at it by race, same thing. The gains between the groups, whether you're white or Asian, is basically the same. Now again, you might look at this and go, what about the other races? There weren't enough blacks or African Americans, again, to draw conclusions from. So this study was limited to basically whites and Asians. If you look at it by ethnicity, so not race, but ethnicity, so Hispanic or Latino or not Hispanic or Latino, you can see that the gains between the subgroups are pretty similar, again, whether Hispanic or Latino or not Hispanic or Latino. When you look at it by baseline best corrected visual acuity, so what was it coming in? You can see that if you saw crappier, we just didn't see as well coming in, you had more to gain. So if you're looking at these two, like these guys are doing so much better, it's because they had more to gain. It's basically the best way of explaining it. But between the subgroups, you can see it's basically the same. If you were seeing better coming in, you have littler gain, but you can see again, it's basically the same between the subgroups. When we do it by central retinal thickness or CRT, if your central retinal thickness was less than 400, so we'll just say that's decent. Again, the gains are same across the groups, but they're less than these guys, right? That's greater than 400 microns, so these guys were not doing as well coming in. They had more letters to gain is the way I think of it. This is basically looking at the proportion of 8 milligram patients who maintain randomized dosing intervals through week 96 by race. So what you really need to look at is 88% of patients were getting at least 12 weeks between injections. That's pretty solid. 84 were going at least 16 weeks between the injections. Again, pretty solid. So what they basically did is added those two groups together, and they're basically saying 90% of all patients are getting at least 12 weeks between injections, which is really, really good, right? And so when you compare the two groups by race to whites or Asians, you can see it's pretty comparable, the 90, the 88 to the 93. And you look at by ethnicity, you can see the Hispanics do a little bit better. It's almost 100%. If you're wondering why, no one really knows. The researchers are still trying to figure out as well. Limitations, this was only designed to evaluate statistical differences. Again, I already mentioned the age and the blacks and African Americans. Conclusions, the 8 milligrams basically demonstrated meaningful best corrected visual acuity gains from baseline, regardless of age, gender, race, ethnicity, acuity, or central retinal thickness. And that's it. Thank you.